Welcome, everybody, to our presentation on implementing telehealth during COVID-19. This is the second time we're giving this presentation. Unfortunately, during our first presentation, we did have some technical difficulties. We think maybe because so many people were joining in that it overflooded the lines. So you guys might be the really lucky ones because hopefully this one will go through without a hitch. If you have any questions, though, or you're having difficulty hearing, you can feel free to type it to us, and we'll try to see what we can do on this end. Otherwise, let's take a deep breath as we all are trying to deal with all of the issues surrounding us during COVID-19. Hopefully this presentation is going to give you some ideas as to how you can better treat and get paid for treating your patients while we're trying to socially isolate. One thing I want to point out is that federal, state, local regulators are all emphasizing the importance of two things. One, treating our patients the best they can, the best you can actually, and keeping people out of the hospital unless absolutely necessary. As you know, we're getting overly crowded, we're lacking supplies and that type of thing. Telehealth is being touted as one enormous strategy to accomplish those goals of keeping people healthy and out of the hospital. So when you're making decisions and what you hear here today, remember those are the primary goals, and I think that the government is going to really accept most things if we work towards accomplishing that, keeping people healthy and out of the hospital. So a few disclaimers about our presentation. Our emphasis today is to talk about the rules that have changed in the past week. We are not doing a deep dive into say the coding guidelines or things like that. Deb is hosting another reimbursement telehealth seminar next week on March 25th, in which she will go deeper into some of those topics on coding and that type of thing. So feel free to go to our website and sign up for that. Altogether, this entire situation is fluid. When we were typing these slides up, we were actually having to change them minute by minute as different rules came out. So things we may say right now might change even by the time we get off this webinar. We don't think that things are going to get more strict. We think there may be some loosening of things, in particular with the payers. We recommend that you and your billers keep an eye on the payer websites to keep up to date with the requirements for how they're paying in telehealth. These are general rules that we're discussing today. Different types of providers may have different types of requirements or needs. At the end, Sandy is going to talk about some unique provider types, such as FQHCs, Federally Qualified Healthcare Centers, and different types of mental health providers. If we don't touch your type of provider and you have any other questions, you can feel free to contact us. There are some other issues evolving with, say, nursing homes and home care that we haven't touched on today in this presentation anyway. We will be taking questions at the end. You can feel free to type them as we go, but we probably will not be addressing them at the end. Our first time around of doing this, we had about 500 people on the line and we got hundreds of questions. So we are trying our best to do as much as possible, but we probably won't get to everything, nor do we know everything off the top of our heads. So we are contemplating having a follow-up session to this. In addition to what Deb is doing on March 25th, we will keep you updated regarding that. But please give us your questions because it helps us inform our decision as to what next steps there are. So let's move forward and talk about just roughly the agenda. We're going to start off giving you a little discussion of reimbursement, Medicare, Medicaid, commercial payers, things like that. We're going to talk a little bit about the HIPAA security issues and the easing of the rules with the OCR. We're going to just touch upon some operational considerations as you move forward with telehealth. And then we're going to talk about, as I mentioned, concerns for specific types of providers. So with that, Deb is going to turn over and talk a little bit about reimbursement generally.
Thanks, Stacy. So as you just heard, on March 25th, we're going to host another webinar, which we actually had prepared prior to the pandemic, that really is taking a deep dive into the mechanics of providing and billing and receiving payment for telehealth services in the tri-state area. For now, this is almost a webinar 2.0. We're focusing on what's changed. So it's a little bit backwards, but we're trying to address the immediate needs of our clients and the healthcare community at large. If any of you are aware of something that we haven't addressed or that we've gotten wrong, because guidance is changing so rapidly, please let us know. We are all in this together, and we will get through it together. So essentially, prior to the virus, telehealth what was covered and what was reimbursable always varied depending on the payer source. Medicare had its rules, state Medicaid plans had their rules, and of course the commercial payers had theirs, and of course by state. To qualify for reimbursement, many payers required that a patient be at a specific location, or what they call the originating site, and that was never a patient's home unless the patient was in a rural area. They're also required, there are a lot of rules around the type of technology that you can use. And in the world of commercial plans, there was always the requirement that you be a participating provider in the plan's network. Under the current environment, the requirements and coverage for telehealth are still going to vary by payer and by state, but we're seeing certain commonalities on restrictions that are being eased. Originating site requirements appear to have been waived almost universally. And this makes perfect sense because the focus of all our public health officials right now is to keep people home. Whether they're sick or whether they're well, stay home. And if you don't feel well, avail yourself of a telehealth option. However, there are requirements that in-network participation remain. And this is getting a little bit muddied because the President of the United States, as well as certain state governors, have issued emergency regulations that permit physicians and other healthcare professionals who are licensed in other states to provide care to patients within a state that they currently are not licensed. That sounds great, and if it's Medicare, it's terrific. But for any other payer source, which is state-related, it doesn't mean that that payer will necessarily reimburse a provider from another state for treating one of its beneficiaries. So the best advice we can give at this point in time is you need to check with the plan. For now, the credentialing requirements and everything else that governs how a plan reimburses a provider are still in effect. And the other commonality that we're seeing, that patient cost-sharing amounts for telehealth services are being waived. And the question that came up in our earlier webinar was whether or not, if a plan is going to waive a cost-sharing amount, one, will the plan pay the full amount for that service? Or two, can the provider still bill the patient for that amount? And I'm addressing it now, probably should address it later on as we talk a little bit more about commercial reimbursement, but I don't want to forget. What's going on now is that I would rely on the EOB that you're getting from a particular payer. The payer will tell you, or should be able to tell you, since all telehealth services are submitted using certain modifiers, whether or not the patient has any cost-sharing obligation. If the patient on the EOB has no cost-sharing obligation, don't bill the patient. If the patient does show as having cost-sharing obligations, bill the patient. If the patient then comes back to you and says, hey, wait a second, my plan said I had no obligation here, I would say, gee, we're sorry, we didn't know, the plan didn't tell us, and then you should be able to, or hopefully, get that reimbursement from the payer. Stacey's going to talk a little bit about the 1135 waiver from the federal government.
So many of you may have been hearing about the 1135 waiver. Actually, before I even start talking to this, a few administrative things. One, at the end of this presentation, we will be sending around a link to a recording of this. I think it's a YouTube link. And we will also be sending around the slides. I don't know how to print them right now, but we will be sending around the slides, so you will have them in electronic format. You can do what you want with them. Also, you know, a thought that has occurred to us as we've been preparing for this whole thing is that telehealth is likely to be changed forever as a result of that. And we think that some of these rules, depending on how it all plays out, these waivers will remain intact. But we don't know that for certain now. We have no way to predict. But if I had a crystal ball, I would say things are definitely changing to make it easier to do telehealth even after this state of emergency. With that in mind, you might have heard a lot of conversation about the 1135 waivers. Essentially, that waiver is part of the Social Security law, and it allows the Secretary of the Department of Health and Human Services to waive certain requirements associated with receiving reimbursement from federally funded healthcare programs. That law exists all the time. The Secretary has to take steps to waive it. It authorizes him to do it, and then he has to waive. He has issued many blanket waivers at this point. When I say blanket waivers, I mean waivers that apply throughout the United States. In addition, certain states are asking for further waivers. We know Florida and Washington have each submitted waivers. I assume New York will be doing so at some time. Be aware that if you have an urgent need, there might be a waiver opportunity there for you as well. Otherwise, we are discussing some of the waivers, the blanket waivers that the Secretary has issued to date. And one of those has to do with Medicare Telehealth. As Deb was saying in the past, if the patient didn't live in a rural health area, the patient couldn't be at home. Now that has been waived. It does not matter where the patient is. The patient could be sitting at home, can be in the park, can be wherever they want, as can the doctor. So both the doctor and the patient can be at any location when billing a Medicare Telehealth service. A Medicare Telehealth service is something that is an interactive audio and video. It's like you're sitting across from one another, except you're on either end of a computer. And that computer can be a smartphone with video capability, or a laptop, or an iPad if they do it, or a desktop, what have you. It doesn't matter. And they are paid and considered to be the same as an in-person visit, these Medicare telehealth visits where there's interactive video. So you're paid as if it was an in-person visit. The types of codes that are reimbursed are basically E&M codes, evaluation and management visits, mental health counseling, and preventative health screenings. For the time being, Medicare CMS will not enforce the requirement that there is an existing relationship with the patient, meaning for Medicare telehealth services, you can interact with a new patient and get paid by Medicare for a new patient if you do this interactive video. Also, Medicare says that you can waive the co-insurance and deductible requirements, meaning that you can decide that you're not going to collect them. That means you will not get paid them. It's not that Medicare is going to pay you for the copay. It's just meaning if you choose to, you can tell patient you don't have to pay them copay. There are a couple other ways that you can interact other than face-to-face, and Deb's going to give you some summary of that.
Thanks, Stacy. So now we're going to talk a little bit about two types of visits under Medicare that actually have been in place prior to the coronavirus, and really nothing is changing about how these work. The first is a virtual check-in, which has been in effect since the beginning of 2019, and it basically allows an established patient, doesn't apply to new patients, but an established patient to call their physician or their healthcare professional and literally check in about how they're feeling. You need to have the patient consent to the virtual check-in, and the consent must be documented in the medical record. CMS has recently issued guidance that you can get one consent for an entire year. So the first time one of your patients calls, get their consent over the phone, document it in the record, and you're good for the whole year. You just have to remember to redo it come January of 2021, et cetera. Not unsurprisingly, these visits are paid at a much lower rate than Medicare. And the last I checked, reimbursement was around $15, give or take. It can be done over the phone, or it can be done via audiovisual communication devices. One thing about a virtual check-in, it cannot be tied to a visit that occurred within the previous 7 days, nor can it lead to a visit that's going to occur within the next 24 hours. Normal cost-sharing rules apply. So to the extent we talk about waivers, it won't apply here. If a patient has a Medicare cost-sharing amount, it must be collected. And again, this option existed before the pandemic, and it will continue to exist when the emergency is over. Similarly, Medicare has allowed for an e-visit, which is a visit that occurs through a patient portal only. It is not a face-to-face visit. Again, like the check-in, the patient has to be the one to initiate the communication, and it only applies to existing patients, not new patients. Payment again here is lower than it would be for a full visit, and the normal cost-sharing rules apply. Unlike the virtual check-in, patients still have their cost-sharing obligations, and once the coronavirus leaves us, this service will still be available. All right, now we're going to move over to the states, starting with New York. New York has had for a nice few years now a telehealth parity law, which essentially requires fully insured plans and the state's Medicaid plan to cover telehealth services on the same basis that it would a service that was delivered in a bricks and mortar setting. Prior to this virus, insurers could subject the coverage to copays, coinsurance deductibles, and quality assurance requirements. And essentially, these visits had to be consistent with how providers handle face-to-face visits. And plans could and will continue to subject the ability to perform telemedicine to in-network participation. On March 7th, the New York State Department of Financial Services issued a regulation that basically requires insurers now to waive deductible co-payments and coinsurance for in-network telehealth visits. The waiver applies regardless of the reason for the visit, whether it's somebody's calling because they think they're sick with the coronavirus or just because, they have a runny nose. So the idea behind the waiver is to really encourage patients to stay home and seek care from their home. It is the overarching reason for all the changes that we're seeing with respect to reimbursement. Here's the big caveat. The Department of Financial Services can only regulate health insurers that are regulated by New York State, which means they're licensed under the insurance law or they're licensed under Article 44 of the Public Health Law, which includes Medicaid managed care plans. These waivers do not apply to self-insured plans. And let me give you an example. United Healthcare offers both insured products like United Community Plan, which is their Medicaid product, and Oxford Health Plans, which is a fully insured HMO under the Public Health Law. And they have a ton of self-insured products typically sold under United Healthcare. Only United Community Plan and Oxford Health Plan are covered by this regulation. And in a recent conversation I had with counsel for United, she explained that whether self-insured plans will apply these waivers to the benefit of their members will depend exclusively on what the employer groups want to do. So you're going to have to, you or your biller is going to have to check with the plans as to whether or not waivers are in place. And again, I think you're going to find that information on the EOBs, the explanation of benefits, or on remittances and prices. New York Medicaid has instituted a telephonic visit as of March 13th. And it will allow a phone call, allow you to bill a phone call based on the time of the phone call. It's in increments of 5 to 10 minutes, another code for 11 to 20 minutes, and then another code for 21 to 30 minutes, as long as that conversation is provided by a physician, nurse practitioner, physician assistant, or licensed midwife. It is to be provided only to established patients, not new patients. And just like the Medicare virtual check-in, it cannot be related to a medical visit within the previous 7 days or a medical visit within the next 24 hours or soonest available appointment. Providers should obtain consent over the phone and document that consent in the patient's medical record. And also, they need to document in the medical record that the telephonic visit was clinically appropriate. So if a patient calls after falling and says, hey, doc, I think I broke my leg, and the doctor said, look, you better get yourself over to an ER to make sure that leg gets set, that conversation is not reimbursable. It's whether over that course of the conversation you are providing medical advice. Moving on to New Jersey, like New York, New Jersey has a rate parity law, and like New York, it applies only to Medicaid managed care and fully insured plans. So the same rules would apply when you're dealing with the self-insured in New Jersey. Before the virus, an insurer could not charge any amount that it wasn't being charged for an in-person visit. And interestingly, with respect to before the virus, if a person wanted to come into the office, you couldn't say, no, I think you can do this from home. Now the converse is true. There's no coinsurance, copayment, or deductible that are being charged for these visits for fully insured and Medicaid managed care members, and patients cannot be discouraged from utilizing telemedicine. New Jersey, so far, New Jersey Medicaid has not instituted a telephone visit like we have in New York. Again, with the collaboration going on among the governors of New York, New Jersey, and Connecticut, could we see New Jersey adding one of these visits? We could. So again, just stay apprised, and we're doing our best to stay apprised of what's happening in our area. Connecticut, like New York and New Jersey, too has a parity law dealing with telehealth services for fully insured and Medicaid beneficiaries. And again, it requires that the telehealth services are subject to the same terms and conditions, including payment rates. We will, on March 25th, we'll get into more detail about how telehealth services have to be delivered in order to qualify for reimbursement. But for now, it's business as usual. The only thing that Connecticut did to loosen the rules is only with respect to Medicaid. And interestingly, Connecticut is only one of 3 states that does not have Medicaid managed care. So this applies to the state's fee-for-service reimbursement. And what they're basically done is that they've broadened the scope of telehealth in Connecticut for the Medicaid population. They have added new patient evaluation and management codes, as well as psychiatric diagnostic evaluation codes. All these things can be done can be done via telehealth, audio-visual communication. Medicaid in Connecticut does not cover telephone visits, and we'll see if that changes. All right, moving on to commercial reimbursement. First, I just want to draw a distinction between providing telemedicine as part of being a participating provider in a plan's network and becoming a telemedicine provider for the plan. I have received some questions about this week. One client said that they were asked to fill out an application in order to do telehealth services, and I think that was really a disconnect between the provider in speaking to the plan. If you're being asked to submit an application, you're applying to become a telehealth provider, like a teledoc for the plan. What we're talking about today is really providing services as a participating provider via telemedicine. The American Health Plan Association put out, at the beginning of March, put out a summary of what the plans are doing across the United States with respect to COVID-19. And many of these plans are waiving or offering certain options for their membership to address telehealth services. The next couple of slides, I provide some examples of what the major plans are doing in our area. But again, fair warning, guidance is changing daily. And I'm just going to flip ahead to Cigna for a moment. So when I looked at the chart prepared 2 weeks ago, it had the first bullet, right? That Cigna is offering virtual visits through their own telemedicine platforms, which happens to be American Well and MD Live. When I looked again yesterday, you can see the second bullet is very specific that they're now allowing their customers with immunosuppression and chronic conditions who are having trouble getting to doctors to be treated virtually 24/7 by phone, tablet, or computer with their in-network physicians who have these kinds of capabilities. That is extremely specific. I hadn't come across anything that specific in any of the other plans, but like we've repeated several times, things are changing hourly practically. Let me just jump back. So, you see that Aetna is offering 0 copays. AmeriHealth is waiving cost sharing for telemedicine visits. There are time frames that you see that the plan is saying, well, we're going to do this through June 4th, or we're doing it for the next 90 days. And figure most of these things went into effect sometime in March, so you can guesstimate as to how long they're going to last. Obviously, based on how we do with respect to this virus, could I see these things going deeper into the summer? It could happen. So again, keep up with these planned websites. Typically, the information about the coronavirus is right on the first page, and if not, you can just put in COVID-19 or Corona, and they pop up pretty readily. So we talked about Cigna. Empire is offering its telemedicine platform, telemedicine through its own platform. They're waiving cost sharing amounts. Horizon Blue Cross Blue Shield is also waiving cost sharing amounts. United has waived originating site requirements for all its products, but it's basing, patient cost share again on the commercial side as to what their employer groups want to do. A little bit about workers' comp. Workers' comp in New York has officially published regulations that allow for telemedicine using audio-video communications that permit real-time communication. So there's no send me a photograph and I'll look at it. That won't work. It does not include treatment where you need that laying on of hands or the physical examination or initial visits or assessments. The authorized provider must indicate that the assessment was done using telemedicine as a result of social distancing. So those are, make sure that you chart that. And there are going to be different codes used depending on the type of provider that's providing the telemedicine service. Again, New Jersey and Connecticut, they have not yet caught up to New York. Could they provide additional regulation to deal with workers' comp for their states? Sure. But right now, so far, it's just New York that has addressed telemedicine. Now I'm going to pass the baton back to Stacy, who's going to talk about HIPAA.
So on March 17th, our very sad St. Patrick's Day, the OCR announced significant easing of the HIPAA requirements in regard to telehealth. And I provided here in the slide the explicit language. You can read that yourself. I'm not going to read it to you. But essentially, what does this mean? It means that during this national emergency in the short term, the OCR is not enforcing against providers who use a telemedicine platform that is not consistent with HIPAA. Okay? So, for example, typically you would need to have a business associate agreement with your telemedicine platform vendor, right? Now, if you don't have a business associate agreement, the OCR will not attempt to enforce against you for that. It also allows you to use any vendor for telemedicine that is not public facing. Now, there may be some contractual terms or state health law, privacy law concerns that come into play, but I'm not sure anybody's really caring about that right now. What this does not mean is that you can disregard HIPAA altogether. This non-enforcement proclamation by the OCR only applies to telehealth in respect to the platforms it's using. Okay, not in regard to anything else. Well, they have issued a few other waivers, like you don't have to hand out a privacy notice. But basically, this latest one only pertains to telehealth and the security of the telehealth platform. There is not a waiver of the requirement to notify patients if their information is breached, meaning that if you use a telemedicine platform that is not HIPAA compliant, and as a result, there is a breach, there is an unauthorized access, use, or disclosure of PHI, you still need to comply with the breach notification requirements. Finally, this does not mean that you can use public-facing platforms, meaning you cannot use a platform that will post your interaction with the patient so that the public can see it. And that seems common sense, but the OCR found it necessary to point this out. They specifically stated that three vendors that they found, products that they found that are public-facing include Facebook Live, Twitch, and TikTok. So you need to definitely avoid those products. Therefore, even though there's been this waiver, some things to consider. We would recommend that whenever possible, and that means when it won't interfere with patient care, you use a telemedicine platform or product for which you can obtain a business associate agreement. It's just, therefore, when you get on the other side of this whole coronavirus thing, you will be in a much better position. Because as much as I said before that I think that telehealth is going to change forever as a result of all of this, I don't think that the OCR is going to say, oh, we don't care about the security of your telehealth systems after we're done with this emergency. So I would expect that the security rules that were in place applying to telehealth will be in place someday again. The OCR, in fact, although this has been my advice all along, it was kind of the OCR's advice as well. Good idea to try to get a business associate agreement if you can and it doesn't interfere with patient care. Some of the products which they found, the OCR found, that will sign a business associate agreement, although they won't opine if that business associate agreement is compliant, but at least these vendors listed here on the slide will sign a business associate agreement with you. So it might be better, if possible, to use some of these. So some additional operational considerations as you move forward in implementing your telehealth program. First of all, I would check with your professional liability and cyber liability insurance carriers to make sure that they will cover the services you provide via telehealth. In particular, if you ultimately start providing services in another state, something to make sure that your malpractice doesn't have a problem with. Second, prescribing of controlled substances. Historically, there has always been a rule that says that in order to prescribe controlled substances, you must have to have a face-to-face interaction. Prior to this pandemic, the DEA was already starting to waive regulations to ease that rule. They have now declared that during the state of emergency, you do not have to have a face-to-face interaction in order to prescribe controlled substances. Unfortunately, not all of the states have waived their individual requirements. For example, in New York, there is a similar face-to-face requirement regarding prescribing of controlled substances. Whether they're going to enforce that during this time, I kind of doubt it, but you yourselves have to weigh the risk of running afoul of a still stated state law. Consent. Each of the states, New York, New Jersey, and Connecticut, require a consent to proceed with the telehealth services. So let me just remind you all, the consent is the conversation. The consent is not whatever form you put it on. So you must have a conversation in which you discuss with the patient the benefits and risks of telehealth. It doesn't have to be long, but just a conversation, and the patient has to acknowledge it. You can document that consenting process in one of three ways. You can have a form that you send to the patient, they sign and send back. You could have it online that the patient clicks, I consent, and with the consent written out. Or you can have a verbal conversation and you document in your progress notes that you had the conversation and the patient consented to the use of telehealth. Any of those three options is acceptable. If you're doing telemental health that Sandy's going to talk about a little later, and you're required in New York and Connecticut to have specific language that is part of the discussion or on the consent form. So if you are one of those types of providers, you can contact us and we can give you some information on that. In addition, documentation. So these services via telemental health are services the same way that in-person services occur, and you need to document them in your EHR. So in the same fashion that you would document what happens during a face-to-face interaction, you have to document what happens during any of these telehealth services. It's very important. You cannot forget about that. And finally, you should be aware when you select a product whether it is storing or recording the interaction you have with the patient. Typically, when we talk to our med mal friends, they do not like to have these recorded. There gets to be, I guess, some legal issues in a malpractice case. But I'm not here to opine on that. I do recommend strongly because if it's recorded and stored by your vendor, when the OCR does go back to enforcing, then you could have an exposure. So you want to be aware and manage those saved recordings if you have them. Okay, so with that, I'm going to turn it over to Sandy, who is going to talk about concerns for some specific types of providers. Sandy?
Okay, great. So there are some providers, there are providers where special rules apply, and we just wanted to go through a few of them today. So the first are federally qualified health centers. Now, under Medicare, currently under Medicare, before any of the waivers were issued for Medicare, FQHCs could only serve as the telehealth services originating sites. And if you recall, the originating sites just means where the patient is located. The FQHC could not serve as a distant site provider. And again, the distant site provider means the provider that's actually rendering the telehealth service. So under normal rules, FQHCs could only serve as originating sites. Now, the waiver that Stacy was previously discussing, that waived originating site requirement, but didn't seem to touch or address the distant site FQHC issue. So it appears that FQHC still can't be the distant site telehealth provider. Now, we reached out for clarification and are awaiting a response. I imagine that maybe this was just an oversight, and we can expect something within the next few days or weeks. Everything is changing day by day, so what's in existence now could very well be changed in an hour or so. Also with Medicare, as Deb was mentioning, Medicare pays for virtual check-ins. For FQHCs, they're called virtual communication services. And Medicare pays an FQHC for these services if it's provided to a patient with at least 5 minutes of billable FQHC communication technology-based or remote evaluation services. It must be billed using a different code. That's the G71 code, either alone or with another payable service. And payment is set at the average of the national non-facility physician fee schedule payment for the virtual check-in codes. And for 2019, the payment amount for code G71 was $13.69. So, I mean, it's not a ton of reimbursement, but it is something that's available. But in order to bill for a virtual communication service, all of the following elements that are listed on the slide must be met. So the patient must have had a billable visit within the previous year. The patient didn't receive an FQHC-related service within the previous 7 days. And it doesn't lead to an appointment or a visit within the next 24 hours or the soonest available appointment. That's because CMS believes that if the contact originated from an office visit that the patient had in the previous 7 days, or if it leads to an office visit or other visit, then payment for that contact in the middle is really incorporated into the visit you had or will have. Also, with respect to Medicaid, now this is not something new, but we thought it was significant enough to remind our New York FQHCs. And this is something we believe is unique to New York, and we haven't seen it or heard about it in New Jersey or Connecticut. But if our New Jersey and Connecticut FQHCs are aware of it, please let us know so that we could research it and potentially reach out to the regulators. So in New York, if an FQHC provider is rendering a telehealth service to a patient while the patient is in their home, the FQHC has to bill the off-site service rate code, and they cannot bill the PPS rate. And our New York FQHCs know that this off-site service rate code is a lot less than the PPS rate. And there's no guarantee at this time that DOH will provide the wraparound payment for this service. So, I think there's still discussions going on, but as of right now, we're not guaranteed that DOH will pay the wraparound. But again, that could change. Also, before the national emergency was declared, HRSA issued a Telehealth Pal that's available on the website, and I included a link. And so there's general guidelines on services and service delivery methods for providing services that are in scope using telehealth. You don't need prior approval. And the PAL outlines telehealth scenarios that would be considered within the health center scope of project. And scenario D includes when the patient is located in his or her home. And there's additional requirements related to that. So you should definitely check that out. But since the national emergency was declared, HRSA's website also has a whole section on emergency preparedness and recovery resources. And there's a lot of guidance out there that includes adding temporary sites to address the emergency. And because things are changing minute by minute, just this morning, HRSA added an FAQ related to the provision of telehealth to non-health center patients, which is huge. And so the question was, may health centers provide in-scope services through telehealth to individuals who are not current patients? And the answer was yes, that the health centers can deliver in-scope services. Remember, it has to be in scope via telehealth to individuals that have not previously been seen or who are not current patients. They're determined to be in scope if all of these elements are met. The individual receives an in-scope required or additional health service. The provider documents the service in a patient medical record, and the provider is physically located at the health center service site or at some other location on behalf of the health center. And it could include the provider's home or an emergency operations center. With respect to providers who are rendering services on behalf of the health center, please remember that the FTCA covers employees and limited other people. That those requirements related to who is covered by the FTCA haven't really changed too much. You could go on HRSA's website. They talk about volunteers and how volunteers aren't automatically covered, but you can apply to have them covered. So just be mindful of that, and please reach out if you have any questions. We also wanted to make you aware of special telehealth rules that apply to certain services, including mental health and substance use. So New Jersey, Connecticut, New York, your current statutes authorize telehealth through certain professionals to provide behavioral health and substance use disorders. That's not something new. If you'd like guidance on what you're currently allowed to do, we can certainly help with that. But there have been special COVID-19 related telehealth guidance from New York and Connecticut. In New York, the Office of Mental Health, providers that are subject to OMH rules and regulations, so OMH licensed and certified providers, can submit a self-attestation to be authorized to deliver certain mental health services. The same holds true for OASAS and OPWDD. OPWDD does not require a self-attestation, and they encourage the use of telehealth to provide services. And as Deb had previously mentioned, in Connecticut, Medicaid and Husky were expanded to cover behavioral health.
Thanks very much, Sandy. Now we're going to go through the questions that we've received, and I have to move closer to the screen.
So there was a question regarding what is the difference between a telehealth visit and a virtual check-in. So a Medicare, this is a Medicare question. A Medicare telehealth visit is where you actually have video and audio real-time interaction. A check-in can be a phone call, and it all has to be initiated by the patient, or it can be a picture that's taken and sent to the doctor. All of those things qualify as the virtual check-in. The telehealth visit that is reimbursed the same as an in-person visit has to be a real-time video.
And the reimbursement for the two are dramatically different, remember?
Yeah.
So there's much more work involved in a real telehealth visit than it is just a phone conversation. One of the questions, how do I print the slides? We are going to be sending the slides out, I believe, later today.
Yes, tonight. Mm-hmm.
Okay, they're coming out. This is a good one. Any thoughts on if these waivers will persist after COVID? And none of us have a crystal ball. I would think that any waiver dealing with money won't persist, right? Because the plans are not going to want to shoulder the additional cost of coinsurance, deductibles, and co-payments on these visits for any longer than they have to. They're going to want to push them back onto the patient. But again, this is just one person's guess.
I would think that some of these originating site issues that are being waived, I think in the future that is going to continue.
Right. So
I mean, I can't promise, but if I had a crystal ball, that would be my guess.
And again, if it doesn't involve the plans paying out any additional money, I think they'll probably go for it, because I think the idea of patients, we never quite understood the rationale behind the originating site in the first place. Is it better to get verbal or written consent?
Right. Once again, it doesn't matter as long as as long as the conversation's had and it's documented in some fashion. That's fine. It doesn't matter.
Some of the questions now are getting a little more detailed on coding. Again, that's going to be something we're going to cover next week. But some of these, I think I'm right when it says, can you build the E&M code? Do you need to add a modifier? Yes, there are different modifiers for telemedicine visits, and I want to say the place of service is O2, but I'm not 100%. We'll get that one answered for you next week.
There's a question about Skype versus FaceTime as a business associate. So I had checks online, and Skype will enter into business associate agreements. I did not confirm that it is HIPAA compliant, but I would guess typically they are because they're pretty mandated. As of 2 days ago, FaceTime was not signing a business associate agreement. Maybe Apple will change its mind with all of this going on. I don't know. But for the time being, it technically it doesn't matter, although I would recommend trying to get a business associate agreement just in case. Go ahead, Deb.
Let's see. For Medicare, would billers use the same office visit codes that we would use if we were receiving patients in the office? Yes, with the modifiers, right? The new codes, there are certain codes, like the codes for a Medicaid, a New York Medicaid telephonic visit, the 99441, the 99442, and the 99443. Those are for Medicaid, New York Medicaid and New York Medicaid managed care only. Anything else, you're going to use your E&M codes with the appropriate modifiers.
If a patient received dental visits less than 7 days ago and then needs a telehealth visit for medical PCP, I don't know why that would be a problem. It's similar to another question that was asked, if a patient could have a telehealth visit reimbursed for Medicare more than once a week. It's a medical necessity determination, Deb, right? I didn't see anything that says you can only have one telehealth visit per week.
No.
So it's just a medical necessity. If the patient needs to be seen twice in a week, then the patient needs to be seen twice in a week. It's the same as an inpatient.
I want to just clarify something. With respect to the codes, I'm talking about codes, not place of service. Place of service, you don't say your site of service is the physician's office. It is it is an O2. Thank you from one of our participants for clarifying that if it's not clear. We're going to drill down more on the nuts and bolts next week.
There's a question for Medicare, must the visit be by phone only, or does there have to be a video component? Once again, it depends what you want to bill. If you want to bill it as the same and get reimbursed the same as a face-to-face visit, it has to be real-time video. If you want to be paid at the virtual check-in rate, that can be a phone call, but you're probably going to be paid less than $20 depending on how long the phone call is.
There's any guidance on telehealth visits with respect to Emblem, which is Emblem has the GHI and the HIP product. There was nothing that I could find, at least on the American Health Plan website, with respect to New York State insured plans. They have to waive if they're licensed are fully insured, which HIP is. They have to waive the cost sharing obligations. Again, it would depend if they're acting as a TPA, a third-party administrator, which I think they have a little bit of that type of business. That would not be, they wouldn't have to waive that unless the employer group wanted to waive. And GHI, I believe GHI is considered fully insured, but I'm not 100%. We'll get back to you on that one.
Sandy, did you want to address any of the FQHC questions?
From my location, I'm not sure.
Oh,
I don't see the question.
Okay. So, it says for FQHCs, can telehealth Medicare visits be telephone only, or do we have to use a video also?
So the requirements are the same, but I just caution you that for Medicare right now, FQHCs, it doesn't appear that FQHCs can be distance site providers. Medicare only waives the originating site requirements, and under.
Sandy, I'm just going to interrupt for 1 second. So distance site is just another word for the provider. So the distance site is just where the provider is located. Originating site is the patient. So you think of originating site as patient, distance site as provider. So what Sandy's saying, FQHCs are not eligible to be paid for Medicare for telehealth services right now, right, Sandy?
To be right. The waiver that Stacey had previously talked about really applied to where the patient can be, and it's not clear that it affected the rule that the FQHC can't be the provider. But we're seeking clarification, and if we get an update, we'll send it out.
There's a question, if you document a conversation in a communication log adequate as a telephonic visit or virtual check-in, or should it be documented as an actual visit? My advice, and Stacey, you can chime in, I think the visit should be documented in the patient's medical record, all visits. I think it's important to keep that, because it's even from the malpractice standpoint, granted, full disclaimer, we're not malpractice attorneys, but if you're giving advice to a patient about a medical condition, it should be in the medical record. What else?
I think that's all we have right now.
Yeah, I think we've got them all. If you're still waiting for an answer to a question, you can type it right back quickly. We're running out of time.
All right, somebody's asking what is a BAA and why is it important? This predates the coronavirus by about 10 years or more. So a business associate agreement is an agreement you have with your vendors to whom you give PHI. It's required under HIPAA. And it is very important because under normal circumstances, if you don't have one, each piece of patient information you give to that vendor is considered to be a breach, and you can be penalized for that. All right, so thank you very much for joining us.
One quick question, I think we have time. Medicare, do we use E&M codes plus modifier? Yes.
Yes. So thank you, everybody, and I think Deb has a few words to wrap up.
Yeah, also, just on the Medicare, there are special codes, there are different codes for the virtual check-in, so again, we'll dive deeper next week on that. Just to wrap it up, I just want to thank everybody for taking the time to join us. For those of you who dialed in at 12, only to get busy signals or couldn't hear us, thank you for sticking with us and coming back. We overloaded the circuits at our 12 o'clock presentation. We are doing our best to stay on top of the legal issues that are arising during this pandemic. If there are topics that you would like to see addressed and we think make sense for the healthcare industry at large, we will do our best to address them, so let us know. Next week, before we do on reimbursement, there will be another webinar that we're giving with respect to the coronavirus, and this one has to do with exiting and entering contracts in this strange new world. That will be Tuesday, March 24th at noon. To register, just go on our website, www.garfunkelwild.com, and scroll to the events page, and it should be pretty easy to follow. Again, thank you all, and we wish you only the best of health.